Morning, everyone, and welcome. My name is Shelly Rich, and I facilitate the Health and Wellness Coalition here in Wichita. And since 2004, we've been promoting healthy eating and good nutrition to all generations living in the greater Wichita area. We have also been hosting the Working Well Conference since 2004, and unfortunately we were planning the 16th annual conference, but it was postponed this August. So we are excited that we're still able to get together this think tank group to network with worksite wellness professionals in the community. So I want to thank you all for joining, and I'm going to turn it over to Matt, who's going to introduce the Kansas Business Group on Health.
All right, well, good morning, everybody. Thank you so much for being here. My name's Matt Tebow, and I'm with the Kansas Business Group on Health. And the Kansas Business Group on Health is a nonprofit membership organization affiliated with the Medical Society of Sedgwick County. Our mission at the Kansas Business Group on Health is to be a resource for employers for increasing the value of their health benefits by improving the quality and reducing the cost. As part of the resources that we provide to our members, we routinely offer training and education on topics that are timely, relevant, and impact both your employees' health and your bottom line. And so we were absolutely thrilled to partner with the Health and Wellness Coalition of Wichita for this program. And I'm so glad that you all are here because we will be learning about a topic that I feel like we often talk about at great lengths, but we rarely have the opportunity to discuss what the employer role in this issue is. So the topic that we'll be talking about today is social determinants of health. And so when we were looking for speakers for today's session, we wanted to find experts that could talk about social determinants of health from multiple perspectives so we can have a clear understanding of both the impacts and also how they manifest in different situations. So today we'll be looking at social determinants of health from three perspectives. We have Sonia Armbruster with us. She's a health sciences educator at Wichita State University in the Public Health Department. And Sonia will provide us with an overview of what social determinants of health are, but also their impact on the community level. We also have with us Dr. Justin Moore, who is the medical director for the Kansas Business Group on Health. And Dr. Moore will talk about how social determinants of health can impact a patient, i.e. your employee's health, from a medical perspective. And then to bring it all home, we're very fortunate to have Karen Mosley, who's the president of the Health Enhancement Research Organization, or HERO, which many of you may be familiar with. HERO is a nonprofit organization dedicated to both identifying and sharing best practices in the field of workplace health and well-being. Karen will discuss how social determinants of health can impact both the health of your employees, but also strategies that you as an employer can use to try to address these needs in the workplace. So we are so honored to have each of these experts share their insights on how to address this complex issue in the different scenarios from the different perspectives. We will have time at the end of the program for questions, but if you have questions as the presenters are giving their presentations, feel free to type those in the chat box and we'll be sure to bring them up at the end of the program. We are recording this session, so if you would like to share it with a coworker or a friend, family member after the session's over, you're welcome to do that. We will also share the slides for each of the presenters along with the recording after the program. So without further ado, I want to turn it over to our experts so they can tell us more about this issue of social determinants of health and how we might be able to address it. So up first, we have Sonia Armbruster from Wichita State. Sonia, I will turn it over to you.
All right. Good morning, everyone. I am delighted to be with you. Thank you for inviting me to be a part of this conversation. I love this work and I love getting to talk about social determinants of health, but more importantly, I miss being able to talk regularly with my colleagues who work in worksite wellness. So it's great to be with you all. I will be watching the chat for any comments or questions that people have along the way. So I hope that you'll throw some ideas in the chat to engage with the conversation so it's less lecture and more conversation, which is a challenge to do in large groups, but I think that's helpful to help all of us see what's going on. So without further ado, my invitation was to ask about what exactly are the social determinants of health. So as I thought about this, I was thinking about that basic facilitation training concept of what So what, now what? So my job is to think about what. I don't want us to spend the entire conversation admiring the problem, but I do think that my job is to provide a foundation to describe how are we framing the challenge that we are discussing today. So hopefully I'll share a few new ideas, but I'm sure I will be revisiting some ideas that you all have around social determinants of health. So first, let's think about what are social determinants of health. According to the CDC, social determinants of health are the conditions in the places where people live, learn, work, and play that affect a wide range of health risks and outcomes. And similarly, the World Health Organization provides a definition of the social determinants of health, that it's the conditions in which people are born, grow, live, work, and age. These circumstances are shaped by the distribution of money, the distribution of power, and resources at the global, national, and local levels. The WHO states that social determinants of health are mostly responsible for health inequities, those unfair and unavoidable differences in health. And we could do a whole conversation on just health inequities, but I am really trying to keep the scope of this thinking about just social determinants of health and what we mean by those. So I suspect, based on some of the folks whose names I saw in this attending, that many of you have seen this presentation from the American Hospital Association, and they have a great slide deck that's available to all of us on their website that describes the impacts of the social determinants of health. And I wanted to kind of begin with the end in mind. So this is thinking that social determinants of health impact us regardless of our age or race or ethnicity, and that they happen in lots of different buckets or segments or categories. So economic health, neighborhoods, education, food. Social determinants of health address those issues of long-standing disparities in health and healthcare. There are a growing number of initiatives to address social determinants of health, both within and outside healthcare. And really, there's work for both to do. And this is a summary of work that was done by the Kaiser Family Foundation, and you can read more about that if you're interested in that. The framing that I'm going to adopt for this conversation focuses more on the way Healthy People 2030 has framed social determinants of health as a place-based framework that outlines 5 key areas: healthcare access and quality, neighborhood and built environment, social and community context, economic stability, and education, access, and quality. So let's just talk briefly about those ideas. About 1 in 10 people in the United States do not have health insurance. People without health insurance are less likely to have a primary care provider, and they may not be able to afford the healthcare services and medications that they need. Strategies to increase insurance coverage rates are important, but so are increasing strategies to get them to take advantage of preventive care and treatment for chronic illness. Sometimes people don't get recommended healthcare services like cancer screenings because they don't have a primary care provider, or because the system isn't prompting them to do so. So throughout this, I want you to be thinking about what are the policies, systems, and environments that we could be promoting to encourage people to access care. So I took a little bit of a Sedgwick County bias in my look at data. There aren't a ton of data slides, but there are a few. And my first slide about that is related to uninsurance rates. And this slide, it looks pretty much like it does for the whole state of Kansas. You can see that Sedgwick County is the red line, the green dotted line is Kansas, and the blue dotted line is the United States. You can see that prior to enacting the Affordable Care Act, we were getting close to 20% uninsured rate. We had 18% in 2010. And then it took a few years to get through all of the legislative hoops and court challenges, but eventually we did have exchanges open up. And once those exchanges opened up, you can see that the curve began to go down. And we, in the last few years, have had 10 or 11% uninsured rate. But still, that's 10 or 11% of the population that is not insured. So what are the policy, system, environmental strategies that we could take to address that? So one of those has been expansion of Medicaid. And Kansas is one of 12 states that has not expanded Medicaid. And in Sedgwick County alone, if we expanded Medicaid, we'd have more than 16,000 people gain access to health coverage. It would be between 130 and 150,000 people statewide. And there would be millions of dollars in annual healthcare spending happening in our own county, but also across our whole state. And if you want to learn more about that, the Alliance for a Healthy Kansas has several fact sheets on every county and information about how that would work statewide. There are a whole host of resources, and if you have questions about that, I'd be happy to ask. But you know, it's not just access to care, because we know that even with access to care, sometimes we still don't have quality care or people adopting healthy behaviors. So while access is critical, quality is equally important. And for a whole host of reasons, even the insured don't take full advantage of preventive health care. In the next decade, Healthy People 2030 has set a goal to increase the proportion of adults who receive all appropriate evidence-based clinical services. So I thought, gosh, what percentage of adults might be getting all of their preventive services? And Healthy People 2030 does a great job of giving us metrics for every single thing that they include. They want to move it from 8% to about 11%. Can you believe only 8% of people are able to take advantage of all preventive services? That just is amazing to me. But it includes things like colorectal cancer screenings, breast cancer screenings, depression screenings, prostate cancer screenings, and blood pressure screenings, but also things like adult immunizations and tobacco cessation interventions. So there are opportunities for everyone here, providers, insurance companies, employers, and employee patients to engage, to accept and use those preventive services more effectively. And just as one data point related to this, it's flu season, it's flu shot season. It's time for all of us to get our flu shots and our vaccinations. And one population health metric we have is around Medicare enrollees. So we can see this is a statewide map going best to worst. In Kansas, about 46% of Medicare enrollees get their annual flu shot. This is a population that has insurance, and only 50% of Medicare enrollees in Wichita, Sedgwick County, take advantage of that opportunity to get their flu shot. So hopefully in your plans and in your employee groups, more people are getting their flu shots, and they might do that more effectively when they have incentives or strategies online. So what are those policies, systems, and environments we can create for them? Thinking about the neighborhood and the built environment. The places people live have a major impact on their health. Many people in the United States live in neighborhoods with high rates of violence or unsafe water or other kinds of health and safety risks. We know that racial and ethnic minorities and people with low incomes are more likely to live in places with these risks. In addition, some people are exposed to things at work that can harm their health, like secondhand smoke or even loud noises. One of the Healthy People 2030 measures for built environment is related to community water fluoridation, and all of our Wichita colleagues will know that we don't have fluoride in our water here. So let's think more about place matters. It's where we live can determine how well we live. And again, I borrowed this slide from the American Hospital Association. As this map indicates, life expectancy ranges from a low of 66 in red to a high of 87 in blue. And it's interesting, you know, as usual, Kansas kind of comes out mostly sort of in the middle. And that's true for a lot of health indicators. There have been some really fun studies done about how even with short distances between two populations, you can see large changes in life expectancy related to where you live. And I picked these two locations because one, they didn't have any Kansas locations from this particular study. And I reached out to a few colleagues across the state and I couldn't find any. So instead I picked the places where my brother lives and where my daughter lives. So my brother lives in DC and I have a daughter who lives in Tulsa. So I picked those locations. And you can see here that even just a few miles away, there are large differences in life expectancy for that area and that community. So what are some of the factors that cause those gaps? There are things like education and income, unsafe or unhealthy housing, access to primary care, and even racial segmentation, residential segregation. So we have many communities that have very limited cohesion and high rates of segregation in neighborhoods, and that contributes to lower health, lower life spans. Just a couple more thoughts about how place matters. There are many gaps across neighborhoods that are related to opportunities for residents to exercise, walk, cycle, their proximity to highways, potentially the unreliable or expensive public transit systems. And so from a policy systems and environment perspective, how do we build more places where it is easier and less expensive to take transit, where people can walk more and bike more? Communities are actively seeking multimodal transportation. And I'm feeling a little old in my work now. When I first started working in public health, I received a CD-ROM that had our bicycle master plan goals on it. And at that time, we had 1 mile of paved bike lane in Wichita, Kansas. We now have a wonderful map of great interconnected paths and lanes on our in our community, but we still have an opportunity to grow the proportion of people who walk or bike to work. Wichita, Sedgwick County has about 0.5% of people bicycle commuting, which is actually a huge increase from where we were, according to the League of American Bicyclists. And the Healthy People 2030 goal is to try to get the whole country to increase the number of people who walk or use bicycles to get anywhere. And right now it's at about 22% of adults. So what are opportunities for work sites and employer and even health plans to encourage people to walk and bike more? All right, so we said there were 5 areas. This is the third: social and community context. We're thinking about people's relationships and interactions with family, friends, and coworkers and community members can have a major impact on their health and well-being. Healthy People 2030 has 12 measures related to this category, and they're things like reducing the proportion of children with a parent who has served time in jail, or reducing the bullying of transgender students. But let's look at a few that might be a little closer to home for you. This is about thinking about increasing social support networks. So research shows that when people don't have social support, they are at increased risk for physical and mental health problems. People who have social support are more likely to make healthier choices and have better health outcomes. So what are the opportunities for workplaces, insurance, and providers to help create conditions where talking about health is better supported? So one of the measures from Healthy People 2030 is the percentage of adults and over 18 who reported that they have a family member or friend with whom they can talk about their health. And right now that's about 87%, and they're hoping to increase that to 92%. All right, economic stability. In the United States, 1 in 10 people live in poverty, and people can't afford things like healthy foods and health care and housing. Healthy People 2030 included social determinants of health focused on increasing employment among working age people and reducing work-related injuries that result in missed work. Let's look at a couple of specific measures that they had about that. One of those is related to reducing the percentage of children who live in poverty. So this is from, you can tell from this map that it's from the county health rankings. And you can see the percentage of children living in poverty in the United States is 18%, in Kansas 15%, and Sedgwick County 17%. But when you break down poverty by race and ethnicity in our community, it tells a more specific story that I was not really aware of. I usually look at the numbers in aggregate and not in the specific, and they tell a powerful story. So what are we doing to lift parents out of poverty? And what are the opportunities for all of us within the system to help affect that? A related measure is food insecurity. Food insecurity estimates the percentage of the population who did not have access to a reliable source of food in the past year. And this infographic was created by Feeding America in their Food Insecurity and Health Survey. You can see national data here. In 2018, in Sedgwick County, according to this same study, from 2018, 13% of people in Sedgwick County were food insecure. which is over 66,000 people. And I'm reminded of a story of a colleague who was a supervisor of a large organization, but that large organization had a number of lower paying positions within that organization. And while she was volunteering at one of the food outreach ministries in Wichita, the Lord's Diner, she saw some of her staff there. So what are our opportunities across the system to create conditions where there are fewer people who are food insecure? And just one more slide to think about food insecurity. This is looking at child food insecurity. So in the state of Kansas, the rate is over 18%. So the number of kids who are food insecure is over 129,000 kids. You know, what are our opportunities to change the system where we don't have nearly 20% of kids experiencing food insecurity, where they didn't know where the next meal was going to come from, and that stress related to food insecurity, all of those stressors influence health outcomes, as you well know, as a key condition. All right, the last thing that I want to share with you is about education, access, and quality. That's of the fifth of the 5 components that Healthy People 2030 framed it as. You all likely know that people with higher education levels are more likely to be healthier and live longer. Children from low-income families, children with disabilities, and children who routinely experience forms of social discrimination like bullying are more likely to struggle with math and reading. They're less likely to graduate from high school or go to college, and this means they're less likely to get high-paying jobs that are more likely to help them with, you know, economics and insurance, and they are more likely to have problems like heart disease, depression, and diabetes. The Kansas high school graduation rate, which is the cohort of 9th graders who graduate in 4 years, is 87%. And here you can see a map across the state. So the darker the blue, the worse the outcome. Education is an important predictor of health. Adults that are more educated are more often employed and tend to earn more than their less educated counterparts. A 1-point increase in high school GPA raises the annual earnings in adulthood by about 12% in males and about 14% in females. So it's not even just graduating, it's the quality, like learning and doing well. One more thing about education. One of the aspirations in the strategic plan for our public school system in Wichita, and this is true for most school districts, USD 259 has some specific measures that correlate with Healthy People 2030. So one of those is increasing the 3rd grade reading proficiency from 21% to 44% on Kansas state assessments. You know, are there opportunities for work sites to engage in social connection and education by creating partnerships with schools to provide mentors and help kids increase that? I mean, frankly, I was surprised that the aspirations were so low. Increasing the high school graduation rate. Within 259, our graduation rate is 74%, and the Wichita Public Schools is trying to increase that to 80% by 2030. And I took this right off their strategic plan that's posted on their website. So what are our opportunities to create increased social cohesion, connectedness in our community, and improve the overall health of our community through opportunities at work sites? And just food for thought. So 2 slides left. In conclusion, there are many ways to frame social determinants of health, and in this presentation, our focus has come from Healthy People 2020 or 2030, which is our national strategic plan for health improvement. And I want to leave you with that reminder. I suspect many of you are familiar with this chart, that only 20% of an individual's health is tied closely to their clinical care. And that, which means 80% of that is about where you live, work, and play, and the behavioral factors that are influenced. Specifically, we've been talking mostly about socioeconomic factors, those social determinants of health. It is my sincere hope that this introduction and review of information you may already know provides a foundation for our next steps in thinking about clinical implications for social determinants of health and the opportunities that think tank members can take to make progress on these formidable challenges. Thank you.
Fantastic. Thank you, Sonia, for that introduction of social determinants of health, I think that was the perfect foundation for what we're going to hear from our next two speakers. And I would encourage you all to think about questions that you have, both for Sonia and for our next two speakers as they're presenting. Something that I thought of as Sonia was just presenting right there is something that we've talked with this group about before in terms of when she was talking about built environment and the places where we live. And it reminds me of the conversation that we had around the redesign of the downtown streets in Douglas, and not just for the purpose of giving people more recreational places to ride their bike, but really because it's an equity issue to help people get from either their home to the grocery store, to work, or to a doctor's appointment. So just to frame some of the things that we've talked about before in this group, to tie it back to social determinants of health, I just wanted to make that real quick connection. So next, I'd like to welcome our next speaker, Dr. Justin Moore, who's the medical director of the Kansas Business Group on Health. And he's going to talk about how social determinants of health can manifest in the medical clinical setting, how it affects patients, again, which are your employees. So Dr. Moore, I'll turn it over to you.
Thank you, Matt. I hope everyone can see my screen here. Let me know if not, as it slowly loads up. So I thought that the easiest way to relate social determinants of health to the clinic would be to look at them through this microscope of COVID-19 that we're living through now. So just to put this problem into perspective, remember that as of last week when I was putting these slides together, we had about 7.8 million cases nationwide and about 215,000 deaths. Those numbers are striking on their own, but when you consider that the United States only represents about 4% of the world's population, but we represent about 20% of all COVID-19 cases and all COVID-19 deaths worldwide, you can see that we are overrepresented among COVID-19 sufferers by at least 5-fold. So to know why that is, we have to review some of the basics of how this virus is transmitted. And I promise this relates back to social determinants of health. So remember that in spite of some of the kind of theatric hotel cleanings and whatnot that you may have seen early on in the lockdown last spring, COVID-19 or SARS-CoV-2, the virus that causes the disease, is transmitted mostly through respiratory droplets. That means someone else is breathing them out. They never touch a surface. Someone within 6 feet or so of the infected person then breathes those in. Now, the particles themselves can become aerosolized, which is just a matter of the size of the actual particle they're traveling in, and can go further than 6 feet. But 6 feet has become kind of the industry standard. We also know that the virus is found in other bodily fluids like stool, blood, semen, tears. We have no idea how important those are in transmission of the virus. We also know that many domesticated animals are infected with the virus. You may have seen reports of tens of thousands of farmed mink dying in various places over the last few weeks. There have been a few case reports of household pets dying. We don't believe that that's a major source of human infection, though. So the risk of transmission really varies according to your exposure. So if you're around someone with a really high viral load, you may be able to be exposed or be infected with a relatively brief exposure, but we think it happens mostly in exposures that last more than 15 minutes and that happen in enclosed spaces where people are not using any kind of personal protective equipment like masking. And you've seen this illustrated in some huge outbreaks within correctional facilities and on cruise ships. Interestingly, airplanes seem to be fairly safe in terms of transmission of the virus because they're so well ventilated. So when you look at our cases versus the caseload in comparable countries like in Western Europe, you see that we were roughly in the same spot as they are now in terms of weekly new cases, but the area under the curve from early March until now is much, much different. We have had a much higher caseload. Remember, we're 4% of the world's population and we represent 20% of the world's cases. And what I want to get across here is that the reasons for this are not complicated. The reasons that we have a higher caseload than anywhere else in the developed world are because we have not limited mobility as much as other countries have. So remember, we have ways to track people's mobility because all of us carry a surveillance device in our pocket that we call a cell phone. And that cell phone constantly pings our location. So people that know how to do this can look and see how mobile people in any population are. So you see in the upper left, our trips to grocery stores never fell, and pharmacies never fell nearly as much as it did in comparable countries. Our time spent in parks and outdoor spaces never fell as much as it did in other countries. And you can see, you could argue that that's not as important given the route of transmission that we know now. And our change in exposure at the workplace never fell as far as it did in other countries. Now that the risk of not limiting mobility could be mitigated by use of personal protective equipment, but you can see that in the United States, represented by the green line in the middle, we never really have gotten up to that threshold level of mask use nationally that it would take to keep the virus at bay. Compare that to places like Vietnam, where the number of cases they've had limited number in the tens of thousands rather than in the nearly 10 million such as we've had. So even though the causes of our poor response to the pandemic aren't complicated, I think the causes of those causes are. So it's fun to look at pictures of people kind of behaving cantankerously, going out to bars and refusing to wear masks and having these really highly theatric protests to mask use and whatnot. But I don't think those are the people that are really the base of the problem. That's a vocal minority. How I would like you to I'd encourage you to think of this problem more along the lines of these questions. Who among us has the ability to control his or her mobility? I'm a white collar worker who makes a lot of money. It really made no difference at all to me to have to stay at home starting in the middle of March. The work that I've done has gone largely unchanged. Even my wife, who's also a physician and covers the hospital, her work has largely gone unchanged with the exception that she has to wear a lot of personal protective equipment now at the hospital that she didn't used to have. And who is it that who among us has the ability to access and trust recommendations on mask use, especially when we've gotten such poor leadership on this at multiple levels of government? So when we think of the people that are most at risk, they tend to be the people who are forced to go into some unsafe workspace or to live in some unsafe space at home, and who maybe don't have either access to appropriate materials for masking or don't have access and understanding of appropriate educational materials when it comes to the need to wear a mask. And so we see, much as we see in every other disease state in America, that people whose socioeconomic status tends to be a little lower tend to be the people who are most affected by this virus. So you can see that if you self-identify as Hispanic, Latino, Black, or Native American, you are roughly 4 times as likely as a white non-Hispanic person to be hospitalized as a result of COVID-19. And that's national data. This is local data looking at confirmed cases per capita. And you can see that the rate of infection among Black residents of Sedgwick County is much, much higher than the rate of infection among white residents. So this is where I start to argue that what we're seeing here isn't really unique to COVID-19. This is just a manifestation of the fact that the people who are susceptible to COVID-19 are susceptible to every other disease state that we deal with in medicine. So we know really without a doubt now that the people who are at most risk for severe COVID-19 illness, that means getting hospitalized, going to the ICU, are people with chronic cancers, chronic kidney disease, lung disease, type 2 diabetes, various heart conditions, immunocompromised states from organ transplants, people who are obese, people who have sickle cell disease, and people who smoke. Now, if you look at any single one of those, the risk of having any of those diseases and having a severe manifestation of any of those diseases is very neatly and tidily predicted by your socioeconomic status. We know with some certainty, but not the amount of certainty that I just shared with you, that these medical conditions probably increase your risk for a severe COVID-19 infection. Asthma, cerebrovascular disease, meaning a history of stroke, cystic fibrosis, type 1 diabetes, hypertension, immunocompromised states from other things other than organ transplantation, dementia, liver disease, being overweight but not yet obese, being pregnant, having pulmonary fibrosis, and having the blood disease thalassemia. So these aren't quite as neatly associated with socioeconomic status as the things that I just showed you, but for the most part, these follow the same rules as the other predictors of COVID-19 severity that we just shared. And so we see that most people, about 80% of people that get COVID-19 have a mild or moderate manifestation of the disease, meaning they are not hospitalized. About 14% have a severe manifestation, meaning they're hospitalized, and about 5% are critical, meaning they're intubated and need a machine to help them breathe. And so we see a case fatality rate in the original population in China of 2.3%. And we all assumed back when that happened that that case fatality rate was probably exaggerated just because of some of the conditions that were present in China and the wildly uncontrolled spread in the region of its emergence. But we've actually seen that the US case fatality rate from the onset of the disease here in March, or the first detection of the disease in February and March until now, is almost identical to that at 2.8%. And that is simply a matter of dividing the known deaths into the known cases. So we know that there are undiagnosed cases floating around out there, but we also know that we're missing about a quarter of the deaths that are attributable to COVID-19 as well. So that case fatality rate seems to be fairly steady and unfortunately fairly reliable. And it is, the burden of that falls much higher in people who are on the wrong end of all of those social determinants of health that Sonia just told us about. So what I want to get across here is that initially people called this the great equalizer. SARS-CoV-2 is a single virus. It's fairly genetically stable. It doesn't change a lot over time like HIV does. Humans are humans. We're all fairly genetically stable. We don't change a lot over time either. And the amount of genetic difference between two people is minuscule, even people of two different races. So the thought was that the virus doesn't discriminate. But we now know that that is absolutely not true. We know that almost all the mortality and morbidity conferred by COVID-19 is unevenly distributed because of social determinants of health. And the biggest one that we haven't talked about yet is age, right? And age, particularly as it relates to people living in care homes. So this is the likelihood of hospitalization according to your age. And you see that for people under the age of about 40 to 50, the risk of hospitalization is fairly low, but that actually goes up exponentially with age, to where it's almost 900 per 100,000 by the time you reach age 85. So what medicine has done, in addition to the usual things that kind of lowercase m medicine does to try to address social determinants of health, is to try to make sure that efforts toward vaccination are distributed evenly among socioeconomic classes. So this is from the Advisory Committee on Immunization Practices, Dr. Beth Bell specifically. And these are the equity strategies that, that the government and governmental agencies are trying to follow when it comes to developing a vaccine. So safety goes without saying, but inclusive clinical trials. So it's very tempting when you do research to go out and recruit a bunch of 20-year-old college students because they're poor and they take money to do experiments fairly readily and whatnot. But the clinical trials for this are very self-consciously including people of different abilities, people of different races, people of different income levels, et cetera, to make sure that the results of vaccine trials are generalizable to the general population. The next thing that we're going for is efficient distribution. Remember, once you get a functioning vaccine, you've only solved about half the problem. Deploying that vaccine can be very, very hard. And then finally, flexibility. So not every state and not every community is alike, and there's a lot of attention being paid to making sure that local communities can distribute and deploy a vaccine to their most needy populations based on their own judgment. And so recently, the NIH and CDC asked the national academies to convene a working group to decide how to do this mechanistically. Like, what are the actual steps that we follow to make sure that this vaccine is deployed in a way that limits the effect of social determinants of health on its effectiveness. And they came up with several recommendations. One is that the vaccine should be free of charge to everyone, right? And that's easy because this virus is costing the US economy like 5% of our GDP. So spending a few $100 billion on free vaccine distribution is the biggest bargain in the history of the world. Their next recommendation was that we should focus on disadvantaged areas to quote unquote remedy racial health disparities. I put remedy in quotes there because it's their word and not mine. It comes across as fairly optimistic. I'm glad they're doing it, but this seems like one tiny step toward the remedy of racial health disparities to me. And then finally, the working group recommended that the CDC should hold back about 10% of the vaccine at any point for use in so-called hotspots. Now, what are hotspots? Hotspots are defined by the so-called social vulnerability index. That's an index that was developed for management of natural disasters, and this certainly qualifies. Don't worry about reading that tiny text. I know that's hard to read. What I want you to pay attention to is how the kind of green and orange counties, which represent places that are more vulnerable on the left, pay attention to how those overlap with the dark red counties on the right, which are places with the highest COVID-19 mortality in America. And you see that there's a kind of startlingly neat overlap between those two. So what the working group said is that the CDC should hold back 10% of the vaccine to be able to swoop into one of these areas and mass vaccinate people in case of big outbreaks. In terms of the rest of the population, it gets very complicated because this is a slide from the Advisory Committee on Immunization Practices where they were trying to figure out who ought to be vaccinated first. And some people made a case for those with those high-risk medical conditions that we talked about before. But that was about 100 million people that have diabetes or who are immunocompromised or whatever. So then they thought, well, maybe essential workers, but those represent about 80 million people. So some people advocated for healthcare personnel, but that's another 20 million people. Some people advocated for everyone over age 65, but that's about another 50 million people. So altogether, this is 200 million people or so that someone or somebody had advocated for, and that's clearly too many people to be included in a phase 1 of vaccination. So the working group instead said that we should deploy the vaccine in at least 4 waves. The first wave, which will be characterized by scarcity, would go to high-risk healthcare workers in hospitals and nursing homes and to people providing home care. That includes first responders and hospital staff, like janitorial folks, clerks, and whatnot. This is because modeling shows that vaccinating those workers who go between patients will save more lives than vaccinating the residents and patients themselves. As that scarcity starts to wane, the working group said we should move on to wave 2 and vaccinate older residents of nursing homes and other crowded facilities like, along with people of all ages with those high-risk health conditions. Now, they only specifically included cancer, chronic kidney disease, and obesity among those possible high-risk conditions, but they said that there would be some local control over that decision making. Wave 3 would go to teachers, childcare workers, workers in essential industries, which will be determined on a state-by-state basis, and residents who cannot easily isolate themselves if they're infected. Think people in homeless shelters, people in group homes, people in prisons and other facilities besides the nursing homes we talked about before. And then wave 4, which will be characterized by finally having an easily available vaccine, will include everyone else, healthy children, young adults, people without chronic disease, etc. But they warned, as we all know, that this would probably not happen until roughly this time next year. And so this is what this looks like graphically. So think of a vaccine becoming available sometime between now and Christmas. We'll have a highly constrained supply, so we will have to use very, very targeted administration to achieve coverage in these high priority populations, like high-risk health workers, people with chronic diseases eventually, et cetera. Then over time, as the number of doses becomes, of available doses becomes higher, we'll be able to move on to waves 2 and 3. And then finally, sometime late 2021, early 2022, we'll be able to shift to a routine strategy of vaccination, much like Sonia touched on with influenza. So when your employees come to you and ask you when they will be able to get a vaccine for COVID-19, I would coach them along these lines. We don't know the dates yet because we don't even have an approved vaccine yet, but I think we will soon. And the strategy will look something like this. Again, with the intention of targeting high-risk folks to minimize the effect of social determinants of health on the spread of the disease. So that's all I have, and I will stop sharing there. You'll have a chance to see my contact information again before the end of today's session.
Perfect. Thank you, Dr. Moore, for that presentation on the clinical side. One thing that stood out to me that is fascinating, sadly fascinating, is that COVID-19 didn't introduce a new set of problems. It just showed a microscope and on the problems that already existed and how those existing problems for the vulnerable populations have just been extremely exacerbated. And so thank you, Dr. Moore, for giving that presentation. I'd like to turn it over now to Karen Mosley. And Karen, who's with HERO and focuses on how employers can help their employees stay healthy and well, is now going to give us the employer perspective on, now that we know what social determinants of health are, how they impact an individual's health, specifically depending on what group you are in. Karen is now going to give us how that all relates to us as employers and strategies that we can use to try to address this. Karen, I'll turn it over to you.
Thanks, Matt. So are you seeing the right screen? I'm realizing I could really use a third monitor right now. Okay, good. Thanks for that visual. Matt, if you could launch the poll, if we were in person right now, which I know we're all really longing to be, I would encourage you to stand up, shake your arms, shake your legs, you know, shake out the chair tension, and if you'll take a look at the poll that Matt just launched, when you sit back down, before today, how familiar were you with the concept of social determinants of health? Expert, intermediate, novice, while you're answering, I'll just say, I want to first say that Kansas has a special place in my heart. I am calling in from my home office in North Carolina today, but Kansas has a special place in my family story. We were stationed at Fort Leavenworth for 1 year, and at that time, it held the record for the year with the most snow in 100 years. It was more than 30 inches of snow that winter, and my North Carolina-born children had the novel experience of walking to school in the snow. There were no snow days, and some of the best sledding of their lives. So we appreciate Kansas for giving us that experience. So the votes are coming in. It looks like the majority are intermediate, which is great. I'm thrilled to know that social determinants of health is getting socialized, and hope that we can give you some additional learnings today at whatever level you are, and some takeaways. I really appreciated the conversation from Sonia and Dr. Moore so far. The public health and medical perspective are so important to the conversation. And so what does this mean for employers? How do we translate this into actionable steps for employees? You are going to see some similarities. I'm going to bring up some points that Sonia brought up, as well as Dr. Moore, on the COVID conversation. But hopefully it will just only emphasize what you've heard so far and not feel too repetitive. So I'll start with a brief introduction. Thanks, Matt, for telling folks what HERO is and what it stands for. Our vision is that all workplaces will positively influence the health and well-being of employees, families, and communities, which means that we must equip employers with the evidence and the tools to do so. Research is our middle name. HERO was founded more than 20 years ago to advance best practices, and during an era that focused on health cost containment for employers. Almost 10 years ago, we expanded to the vision that I just mentioned, and we are committed to collaborative applied research, which aims to help employers understand the health and well-being practices associated with superior health and business outcomes, and hoping to translate some of that for you today relative to social determinants of health. We are focused on the questions that will benefit employers, consultants, industry vendor suppliers, and the industry as a whole. And I just want to emphasize, we do think tanks too. I was thrilled to see that this was called a Think and Do Tank, and I feel right at home, since HERO also convenes think tanks of our members to discuss important and complex topics that are at the forefront of employee health and well-being. Health is personal, and it's a national resource. It allows people to engage with life, and without it, people cannot share in loving relationships, contribute to their communities, or fully participate in their work. Sonia and Dr. Moore have demonstrated how health is impacted and how it is determined, and so now we'll talk about how employers can positively influence health. A 2019 report published by the Bipartisan Policy Center and the Beaumont Foundation asks employers to consider this question: is our community thriving, healthy, inspiring, attractive to talent, or is it deteriorating, sick, and unsafe? Your answer will shape your approach towards social determinants of health intervention. HERO is always thrilled to sit around the table, and I mentioned our approach to research, which is collaborative, albeit our recent table conversations have been virtual, but with other organizations trying to improve health and well-being. One of those is the Wellbeing in the Nation Network, or WIN Network, and they have an affinity group especially for employers called Win with Business. HERO is a proud partner, along with the National Alliance for Healthcare Purchaser Coalition and others. They've created the Vital Conditions Framework, which is closely aligned to social determinants of health concepts, and it helps to visualize, if you think about the vital signs of a person, it helps you to visualize the vital signs of places. They have a number of briefs that dive deep on this, and so I would encourage you to take a look there for additional learning. So why should employers invest? Whether that's time or money. From a public and population health sciences perspective, the Community Preventive Services Task Force has identified several benefits to multiple stakeholders, including the business and industry sector. Improve the health of family members to further reduce healthcare costs. influence other levers and drivers of healthcare costs beyond the workplace setting, enhance your corporate reputation, draw new talent to the community, and retain current staff. The priorities will differ from one place to the next, but the best place to start on this journey is with the data. And a few good sources for community data. Sonia has already pointed out some, as has Dr. Moore, the American Community Survey, County Health Rankings, the U.S. Census Bureau. Kansas Health Matters was my source for the next few slides, and they draw on these data sources, but also your own employee data will be important to the decision making. So these next few slides are presented just to give you a flavor of how the data in Kansas counties look for a number of social determinants of health that we've highlighted in the paper, in the report that is the basis for this presentation. Location influences so many things, as Sonia pointed out: access to food, transportation, housing, employment, healthcare. Zip codes do matter more than genetic code. Let's see. So this particular graph shows the percentage of individuals who live reasonably close to a park or recreational facility. So access to exercise. The lighter the shade of blue, the more positive the data. Hopefully you can find your data. I realize it's kind of small, but you'll get the slides so you can enlarge them. Adults living in poverty, and I know Sonia pointed to this with her children living in poverty, have a higher incidence of diabetes, heart disease, stroke, obesity, depression, and premature death. They're more sedentary, smoke more, and are more likely to have unhealthy diets. This shows the percentage of Kansans living below the federal poverty level, and this data, the most recent, is from 2014 to 2018. Food security, also touched on in the previous conversations. Good nutrition, of course, is critical to long-term health, and finding food is a challenge for millions of Americans. Important to note, full-time employment does not correlate to food security. So this shows the percentage of population in Kansas that experienced food insecurity at some point during the year in 2018. Loneliness impacts health outcomes, and I know connectedness has also been mentioned. And it impacts in ways that are comparable to smoking and alcohol use and obesity, high blood pressure, and sedentary behavior. It reduces life expectancy as much as smoking 15 cigarettes a day and impacts employee productivity. This graph shows the percentage of the population 65 and older who are living alone. So while not the majority of the workforce, I just wanted to point out that the importance of looking at the social connectedness of your workforce. Work is also a social determinant of health. Thanks to Matt for mentioning the built environment. And the benefits gained from employment can positively impact health, of course. Health insurance, as Sonia mentioned, is an important benefit. And so just further hitting home the point about the importance of having an insured workforce because of the ability to access health in a much easier way, particularly preventive services, which has been one of the factors that COVID-19 has brought to the forefront because so much of that has been put off. Education, Sonia, I know, showed a graph about high school graduation rates. Research has also shown that those with less education tend to have fewer employment choices, leading to positions with low autonomy, job insecurity, and low wages. So this graph actually shows those in Kansas 25 and older with a bachelor's degree or higher, which has also been shown to relate to employment opportunities, of course. Not as commonly discussed, but I appreciate that Sonia has brought it up, well, I know Sonia brought up race. Sexism in the workplace highlights several disparities as well. Women are underrepresented at every level, and women of color most of all. The 2017 U.S. Census reported that the income for women was 80.5% of their male counterparts, and the gap widens with women of color. This disparity is magnified in occupations with limited family leave or childcare and discriminatory compensation and hiring. So this graph is just to show the prevalence of the female workforce in Kansas. Last slide on Kansas data. We've already noted the salary gap between men and women, and of course, and the gap widens when comparing salaries of white men versus men of color, even when considering level of education. One study assessing occupational health disparities concluded that ethnic and racial minority groups are more likely to experience poor mental and physical health due to workplace inequalities, significant to the SDOH conversation. So quick review, the first step in this process is awareness of the issues, awareness of the various social determinants of health, and what the data says about your community. Location matters. Financial stability is tied to physical health. Food security can impact even full-time employees, and social isolation negatively impacts productivity. So let's move on to the next part. All of the information can be overwhelming, but you're not in it alone. In 2013, HERO initiated an environmental scan of employer community collaborations in the US in which stakeholders from multiple sectors were focused together on targeted community health improvement initiatives. The scan was funded by the Institute of Medicine and followed quickly by 2 grants from Robert Wood Johnson Foundation in 2014 to 2016. Those studies looked at the value proposition for businesses to invest in the communities where they do business, so laying out the why, what, and how, and to develop measures that matter to businesses wanting to partner in a multi-stakeholder community health effort. The get-hwhc.org website was created as an open source resource to achieve these objectives and to highlight other resources, tools, and case studies from other organizations. We'd love to have Kansas represented, so I hope you'll submit one. Businesses that want to do well by doing good will often find ready partners in the community who are trying to solve some of the same issues as employers who have identified social determinants of health to focus on for their own workforce. But becoming engaged in an effort to improve community health can be a challenge for employers, especially if the effort is new. This roadmap to success on the website offers insight into those stakeholder groups that are often part of a community collaboration and describes the roles those stakeholders play. In addition, we point to case studies that highlight the roles of each stakeholder on the map. So now we'll launch our next poll, Matt, if you could, and I'll just talk through these types of stakeholders that you'll find in your community. So where can employers, small, mid, and large, find community partners? Community development is a source for economic development support. Government and public health can provide access to data, deep knowledge of the communities. Schools, K through 12, can be a source for nutrition and physical activity, strongly connected to education. Healthcare, of course, has a deep commitment to the community's health and is often a primary convener, has credibility and knowledge. Higher education has access to research and grant knowledge. Philanthropy, short and long-term funding and knowledge of sustainable funding strategy. Nonprofits, mission-centered, and knowledge of community needs. So I'd love to see who you've partnered with, if you've done any community partnering. And we'll give a second for the poll to get some volume on responses. So far, nonprofits, healthcare, those are the top 2. Community development, glad to see that. So as I mentioned, there are case studies around all of these conveners on the website, but we really do want to add more. So I hope to see Kansas there very soon. Matt, you can close the poll. Thanks. Oftentimes, anchor institutions, universities, healthcare systems, and other organizations that are rooted in their communities will be the convener of a multi-stakeholder health initiative. 2 decades of lessons have taught us how to leverage the economic power of universities as they relate to targeting community benefits. Here are 2 spotlights from the university and healthcare sector. The University of Southern California is focused on increasing employment in the zip codes surrounding its campus, and their employment applications demonstrate that that effort is paying off. Geisinger has led a program that empowers employees and patients to eat better with its food prescription program. It's improving access to healthy foods and bringing together a hospital and local food bank. However, employers can be leaders in these efforts too. A few examples of directly impacting the social determinants of health of their workforce. Tom's of Maine pays 25% above the living wage. Several Silicon Valley employers have formed a nonprofit collaborative to address affordable housing in the region. Campbell Soup brings together government, nonprofit, and other businesses to improve food security in the area. And Walmart and Pepsi extend their employee health initiatives to their entire value chain, suppliers, communities, and the general public. So your business directly impacts employee social risk factors and social needs. You are accountable for the work environment you create, and let's talk about how you can work on that. So I'm not going to leave you here with this awareness and charge of accountability and no direction on the next step. Get ready for a message of hope and low cost actions that can make a high cost impact on the health of your employees. First, consider health in all policies. The CDC Health in All Policies is a collaborative approach that integrates and articulates health considerations into policymaking across sectors to improve the health of all communities and people. It recognizes that health is created by a multitude of factors beyond healthcare and often beyond the scope of traditional public health activities. Public health cannot be the only sector focused on health. COVID has taught us that much. The teachable moment of COVID-19 provides enormous policy opportunity to confront issues such as the health influence of hourly wage, childcare benefits, remote work options, paid leave, work furloughs, home care, and elder care. And we'll dig a little bit more in that in just a few minutes. The impact of existing company practices on workforce health in all aspects of business operations must be considered, even in areas that don't traditionally impact employee health, like sustainability and supply chain management. Health in all policies and practices can become a new organizational mantra with measurable quantitative benefit. So to improve employee well-being and sustain high-value business performance, employers must focus beyond physical health. It's not prescribed by a doctor, therapist, or health system. These next handful of slides are meant to grease the wheels and explore what business leaders can do to ensure you're promoting a healthy, high-performing workforce and addressing social risk factors and needs. So first, what is your organizational philosophy and how is it operationalized in daily work practices? The actions here can be simple. Socialize internally these concepts of social determinants of health. Pay a living wage. Train managers to use appreciative inquiry to probe for life circumstances that may be contributing to performance issues. According to Gallup, 70% of variability in employee engagement is driven by the manager. Hero has done a lot of research around the importance of culture to employee outcomes like productivity, satisfaction, and participation in well-being initiatives, and have found that organizational and leadership support are critical to achieving positive outcomes. Consider what workplace factors are interfering with employees' ability to do their jobs and maintain well-being. Specifically, create policies that value health, like paid time off for medical appointments, subsidized childcare, leave policies that include caregiving, and model enforcement throughout all levels of leadership. Do an environmental scan of the community for resources that are available to address social needs. You may not need to create something that's already out there. One of the most important things I can tell you today, listen to your employees. Ask them which social services and programs would be most valuable to them. Kaiser Permanente uses an anonymous employee survey. You could use focus groups also. And leverage existing vendor partners like EAPs, on-site social workers, financial partners like 401k or insurance, and your health plans to understand employee data. Remember, start with the data and listen. So what do your employees need in terms of equitable work scheduling and pay? Assess your practices for norms that could be barriers to well-being for some employees. Grayson Bakery, one of my favorite examples of a small company addressing social determinants of health. It's located in Yonkers, New York, and they supply the brownies for my favorite Ben & Jerry's ice cream, chocolate fudge brownie. They have an open hiring policy, which means that they hire the next person through the door when there is a job opening. A couple of things happen when you do this. They're hiring a larger proportion of incarcerated individuals, and they're saving approximately $4,500 per employee hired in recruiting costs. They use that money instead for training and education, directly addressing the cycles of poverty that impact health status in their community. Integrating work and life includes focusing on behavioral health issues, especially stress and depression, and especially at this time, as well as workplace culture. So try to reduce the stigma associated with mental health, create a safe setting for employees to share in private, and foster those social connections. Is the healthy choice the easy choice in your workplace? What are the barriers and challenges? Create easy access to natural light, affordable and nutritious food, smoke-free environments, filtered water, walking paths, and quiet spaces. Employees may not have access to such amenities anywhere else during their day. Okay, so we covered a lot of ground, but a quick summary is: connect the dots with sustainability, talent retention, attraction, profitability, and safety. Be more intentional with the things that you're already doing in philanthropy, action with current leadership roles in the community, and extend your corporate strategy by participating in multi-stakeholder community work. Leverage your technology, services, products to support initiatives outside of the workplace walls, thereby impacting the health of your employees inside the workplace walls. COVID-19 has amplified the social determinants of health that exist, as Dr. Moore so beautifully laid out. And so let's talk about the business case for employers to address that. We've all seen the headlines. COVID-19 has presented an increased burden and impact depending on one's pre-existing conditions, living conditions, employment, access to care, and food security. To quote the Washington Post, September 30th, the COVID-19 recession is the most unequal in modern U.S. history. The recession's inequality is a reflection of the coronavirus itself, which has caused more deaths in low-income, communities, and severely affected jobs in restaurants, hotels, and entertainment venues as Americans tried to avoid crowded places to protect their own health and slow the spread of the virus. Jobs in these places typically pay on average $17 an hour, and were overwhelmingly held by women and people of color. No other recession in modern history has so pummeled society's most vulnerable. A 2019 Bank of America Workplace Benefits Survey found that while 88% of the surveyed employers offer some type of caregiving resources, 71% of the workers were unaware of these offerings, and only 34% had taken advantage of them. Addressing this gap is essential for caregiving benefits to make a significant impact on employees' productivity, as well as their physical, emotional, and financial well-being. The Bank of America survey also found that employee caregivers spend an average of $6,500 annually caring for children and about $3,200 caring for other family members. And they miss about 12 hours of work per month because of caregiving responsibilities, including providing transportation to medical appointments, grocery shopping, managing finances, and paying bills. In April and May of this year, a team of researchers from the University of Pittsburgh conducted a survey to identify the specific effects of the pandemic on families and family caregivers. The survey assessed impacts on employment, financial well-being, social interactions, health behaviors, and physical and mental health. Decades of research have already shown the impacts of caregiving leading to chronic stress and negative health outcomes. COVID-19 has added complexity given stay-at-home requirements, reduced access to health care, and vulnerability of individuals at higher risk. These sustained restrictions on schools and business impacting working parents and caregivers is causing employers to take a closer look at employee, caregiver, and parental leave policies. Prior to COVID-19, it was estimated that 1 in 5 adults were impacted by mental illness in the past year, with only half receiving treatment. In mid-July this year, a Kaiser Family Foundation tracking poll showed that 53% of U.S. adults reported negative impact on their mental health due to worry and stress over coronavirus, compared with 32% in March. Other negative impacts include difficulty sleeping, increases in alcohol or substance use, and worsening chronic conditions due to worry and stress over COVID. Isolation and loneliness present specific mental health risks for adolescents and older adults. Women with children under age 18 are more likely to report major negative mental health impacts than men. Frontline workers are experiencing burnout, those with poor physical health as well. Those making less than $40,000, all are experiencing poor mental health. So while the COVID pandemic offers a singular teachable moment for employers intent on protecting and advancing the health and well-being of their workforce and communities, business leaders are factoring in differences in their employed populations by zip codes, health status, job requirements, essential services, hourly versus salary, and deciding how to best respond to the public health guidelines and state and local mandates. The short and long-term health of the economy is inextricably linked, as Dr. Moore has already pointed out. So questions about how to keep the response to disease risk proportional to social and economic risk need to be addressed. COVID-19 highlights the role of employer leadership, policy changes, and group-level strategies needed to contain a pandemic, and has highlighted shining corporate examples of business stepping up to the challenge. United Health Group is one of those. In addition to the $40 million that United Health Group invested to support healthcare workers and states with an outsized impact of the virus early on, they also invested $5 million to address social isolation among seniors. They invested an additional $5 million to support those experiencing food insecurity or homelessness, partnering with National Health Care for the Homeless Council and Feeding America and Meals on Wheels. In the Twin Cities, they repurposed closed office cafeterias to provide 21,000 meals a week, keeping low-wage cafeteria workers employed and addressing food insecurity in the community at the same time. The HERO Healthy Workplaces, Healthy Communities Committee recently released this report, the basis for much of this presentation. And it's one of many resources that are publicly available on the HERO website. There are other good resources listed here as well, and new ones being released regularly. I'm glad you'll get the slides so that you can take a closer look. But just know that this is a national priority, and many organizations are working hard to support business in doing well by doing good. So now I challenge you. What action will you take in the next 12 months to address social determinants of health for your employees? Thanks for your time and attention. I hope you found information here to think about and to do, and I look forward to your questions. My door is always open if you'd like to discuss further.
Wonderful. Thank you so much, Karen. That was a fantastic presentation. I think it really brought home the points that Dr. Moore and Sonia both made in their presentations, and it made it very actionable for employers to be able to take back to their individual workplaces. And so I have a few questions that I jotted down, but before I just hog the show here, I want to open it up and see if anybody else has any questions for any of our presenters here. We did have one question come through the chat, and Sonia, I saw that you answered a question from Abigail, and so I want to go ahead and ask that question to Karen as well, because she posted during Karen's presentation. So Karen, the question, and Dr. Moore, feel free to chime in on this, and Sonia, if you have any other thoughts in addition to what you said, please feel free to chime in as well. But the question was in relation to partnering with schools to encourage health, and the question was, how do we ensure that our local schools have access to kitchens with adequate tools and resources that create real healthy meals for our kids? And if we have anybody from the school district on too, yeah.
It's a great question. I know of examples where employers are using schools and families in schools to collaborate on nutrition classes. Access to kitchens, though, I could see a partnership just like actually applying the one that I just mentioned with United Health Group, cafeterias in large corporations that exist in your community, could be a viable collaboration to be able to access that built environment at the workplace and have a collaborative win-win for both education and the business.
Great, thank you. And Sonia, I'm going to read your response out loud because I thought you had a good response to Abigail's question. And so, Sonia said there are different considerations to this question. So they're different from district to district. Most schools in the 259 district do not have kitchens. So it could start with just simply asking the questions to the schools. But there are other opportunities, like Karen just said, to partner with schools to address social determinants of health. Well, one question I had, while you all are thinking of your questions for our presenters, loneliness was mentioned, Karen, in your presentation, and we've also heard a presentation from Dr. Moore at one of our previous healthcare roundtables about this issue of loneliness. And so we know it's a major issue, even just during normal times, not to mention COVID-19. And so with this being even a bigger issue now, and with people, some being forced to be at home while they're at work, or we're generally encouraged to stay home, how can employers specifically help their employees address this issue of loneliness while we're working from home and sometimes forced to be separated from each other?
Yeah, thanks for that question, Matt. I'm glad you brought it up because I made a note during Dr. Moore's presentation to touch on this and I totally forgot it. So I'm glad you did. We are hearing so much from many organizations of all sizes who either already had employee resource groups in place or have established employee resource groups because of the COVID pandemic. And they run the gamut. In fact, we just had a large conversation about this in our fall think tank meeting, talking about connecting during this time, how to leverage technology to do so. I think we're probably all experts in Zoom. We could probably open our own consulting companies on it at this point. I'm not going to because it makes me crazy, but Zoom can be leveraged, or Microsoft Teams, or I think Google, there's a Google, anyway, there's lots of different avenues. And I know that that employers are identifying, are calling for volunteers. What's your special interest? Do you want to establish a connection group on, and literally fill in the blank, quilting, book club, or even workplace issues, diversity and inclusion? Like, really, the list is infinite. The possibilities are infinite. And they're also, leaders are establishing more opportunities to connect, so that employees are not left wondering, how am I doing? What's my manager thinking about? They're offering Zoom coffee dates. They're offering lunchtime. The teams are getting together for a virtual lunch together once a week or once a month, or whatever fits your cycle. I can say the Hero team was virtual before. We were a remote team before COVID hit, but what I didn't anticipate was that, and so I thought, well, we've got this. We do this. This is what we do. I didn't anticipate the impact, the negative impact that COVID would have on mental health with regard to social connection, because our team relied already so much on our external, outside of work social connections, and those got taken away instantly. And so we also were left struggling and trying to figure out how we were going to, boost everyone's mental health. We have added a connection of the day to our weekly team calls, just extra time in our team calls to talk about anything except work, and we'll throw out crazy questions and, what's your favorite kitchen gadget? I mean, literally just everything's on the table. So, and I heard a presentation yesterday. Actually, we finished up our forum offerings, and we had the university summit, and specific to well-being and connection, the university that was speaking put out a call for, hey, you know, what's your skill, or would you like to have a beginner guitar lesson or a cooking lesson, all virtually. So just, you know, it goes back to ask your employees and listen, and leverage this technology that we seem to be stuck with for the foreseeable future.
I think those are good thoughts. The other part of this that I think is important is highlighted by some recent data that Dr. Jean Twenge put out. She's a child and adolescent psychologist that's well known for studying social media. And her data indicates that, at least among kids, the effect of social isolation during the pandemic has been less severe than many had anticipated. And her working hypothesis is that it's because the kids are getting more sleep now than they were before the pandemic hit. And the extra sleep is mitigating the adverse effects of the loneliness. So to me, the way that translates to the workplace is to make sure that your employees know that at some point in the afternoon or evening, they can shut off Zoom and know that work is over. We've all worked with employers or coworkers who were notorious for 1 a.m., you know, spur of the moment text messages and whatnot. And it was bad before, and I think it's especially bad now. So we need to make sure that we discourage that kind of thing.
Yeah, I completely agree. And I would just add that leaders modeling that behavior is so important. I remember hearing a presentation pre-COVID from one of the Hero Award winners a couple of years ago, and she instituted a no email on the weekend policy. And I think that now more than ever, those types of policies are worth revisiting and with even more emphasis, because it is so hard to, you know, I was talking to someone the other day, he said, you know, my laptop's on my dining room table, so now I have to close the laptop and put a book on top of it when it's non-work time, because otherwise when I walk by, I'll sit down and just do more work. So it's important to draw those lines.
Great, thank you. Those are great suggestions. I'm going to pause for a second to see if anybody else has any questions before I rattle off a couple others. I feel like this is a Matt Tebow personalized presentation here with all the questions I have, because my pen was on smoking on fire from all the questions. But I want to open it up to see if anybody else has questions before I ask another. Okay. Well, we've talked about, Karen, this one's kind of directed at you again, but I would encourage the other presenters to chime in if they have thoughts as well. And so when we talk about strategies that employers can implement to try to address social determinants of health, a lot of them are at least from what I've gathered, kind of financial in nature. So increase their pay, offer more time off, increase their benefits. And there was a Harvard Business Review article that looked at Costco versus Sam's and the benefits that they provided and what it did to their bottom line and their employee retention and things like that. And essentially what they had done is they had offered more robust benefits for their employees. But as we know right now, that can often be difficult for employers just in normal given times, but especially right now with revenues being tight. And so I wanted to just pose the question of what are some potential effective strategies that employers can use to address social determinants of health that have little or no cost?
Yeah, thanks, Matt. So some, I'll repeat a few that I named. Creating safe spaces for employees to be able to talk about the things that they are facing outside of the workplace walls, socializing social determinants of health internally, destigmatizing mental health, in the workplace, training your managers. I realize that could have a financial price tag, but I can't overemphasize enough the importance of manager education and leadership modeling some of these strategies that I've laid out, and also doing a scan of what's available in the community, because often there are resources in the community that will help to support the employee needs and who are at risk without without the employer having to spend a dime. Listen to employees and look at the data. I mean, I think that it's easy to instantly assume that high cost initiatives are needed to address some of these things, but your data might show you a different picture. And so listen to your employees, look at the data, leverage your community resources.
Thank you. I apparently missed those when I was writing, so sorry I missed those. Thank you for sharing those again. Sonia, I have a question for you, kind of on the community level and how employers can fit in. So one of the things we talk about a lot at the Kansas Business Group on Health is utilizing our collective voice to enact change that we'd like to see kind of on a community or policy-wide level. And I'm just wondering if there's any role for employers to try to, whether it's, you know, advocacy or talking to elected officials or some other avenue that employers could take to try to, for instance, built environment to make our city more walkable and bikeable, for instance. Are there any things that employers can do to kind of push some of those initiatives along that you can think of?
Well, I do think that employers have a tremendous power. They have regular opportunities to be in conversation with elected officials, and elected officials lean on them for advice and information. I mean, thinking specifically about COVID, there have been several convenings of leaders in business that were convened by, say, the county commissioners or city council members, wanting to hear back from them about policy guidance and how that would impact them. You know, when I think about places where I'm seeing, I mean, this isn't like a worksite wellness kind of thing. Well, it is. There are mask utilization is enforced most effectively by work sites that are requiring mask wearing. You know, there's a real power for that. And I think that, you know, when it comes to the built environment, I think that employers can model the way as well. So is there a bike rack at the employer site? Is there an opportunity to, is there a place to convene and address these social connection issues? You know, I'll share an example from a former office where I worked. We moved from a place where we had no place to convene, like everyone had an office, but we didn't have a central hub where we could get together. And the office moved to a place where there was a central place where people could get together. And suddenly a jigsaw puzzle became a continuous part of the culture there. And there was always a jigsaw puzzle. And at lunch, you could see 5 or 6 people who weren't on the same team talking and trying to place 10 pieces of the puzzle. And then they go back and do their thing. But it created little mini connections for social good. So I think there are lots of small ways that employers can create connections for their workforce. I think there are several small ways where they can influence adherence to good public health practice. And I think there are several big ways where they can influence, well, they are thought leaders with elected officials. And if it's important to you, employers, that we have a more walkable, bikeable, healthier option for food influences, then I think elected officials are very keen to listen.
Matt, I can just share that that our recent, throughout the September and part of October, Hero was offering a virtual fitness challenge. So we were leveraging sort of group dynamic, social connection to teams of 5 were competing in this fitness challenge, steps challenge. It included a conversion for biking. And it really did, I think, serve to make individuals aware of their own activity, but it also gave a social connection, group cohesion type of impact to it as well. That's very, I won't say it's no cost, but it's a very low cost way to sort of leverage a couple of the concepts that we've talked about, connection and activity, physical health.
Yeah, Karen, that made me think of another way that I've seen employers have a tremendous impact on just utilizing and engaging with the community. So you mentioned all of these community partners that in one of the polls and one of the slides. And, you know, I've seen some colleagues of mine who are not the first to sign up, like they're not the team captain for the Walk Kansas work, you know, like the people who are less likely to be walkers, movers, shakers. But if the whole work site is going to put together a team to go be a part of this, you know, Step Up for Kids or Alzheimer's awareness walk, or insert every fundraiser walk there is, if there's a team community kind of a feel, you'll pull along people who aren't necessarily into that sort of thing, and they get out and they see their friends and neighbors and they get a t-shirt, and it creates both connectedness and engagement with the community, and moving, and there's momentum building, and it doesn't take that much effort to encourage people to join a walk, or to create a 5-walk challenge like over this season, you know, from March to October, while we have all of these community walks. You know, we're going to have a challenge that we participate in 5 of them or whatever. Like there are whole communities that do that sort of thing. So there are low-cost ways to bring people together and motivate and encourage them to do this sort of thing. And I know you guys in the think tank have talked about these kinds of things in the past.
Thank you. Those are great suggestions, and I'll just remind everybody, Shelley, not to steal your thunder, that it is Walktober right now, so a perfect community walking initiative to get into right now. I do have a question for you, Dr. Moore, and then I have a question that I'd like to pose to all the attendees to get any feedback that anybody would like to share. But Dr. Moore, I'd like to ask, from a benefit design standpoint, to try to address social determinants of health in the clinical setting, are there any things that employers should consider when designing their benefits on how to encourage the addressing of social determinants of health, either in the clinical setting, whether that's reducing copays or making certain resources available? Do you have any suggestions on that?
Well, I think you touched on one. So over the last, since 2008, we know far and away the most popular strategy amongst employers for trying to reduce the rise of healthcare costs has been cost shifting, right? So it's shifted more of the cost toward the employee. About 2/3 of employers have employed that strategy. And you're right. I mean, everything comes at a cost. I understand these are hard decisions to make, but we have good evidence to show that higher copays, higher deductibles lead to both a reduction in preventive services that are used by the employee, as Sonia talked about earlier. We know it affects adherence to medications. Remember, any particular chronic disease medication a person is prescribed has about a 50-50 chance of still being taken 1 year later, has about a 30% chance of still being taken 2 years later, even if it's still being prescribed. The biggest predictors of that are cost and convenience. And so the one that's available to the employer to manipulate most easily is the cost. So that's where I would start. The short-term temptation of cost shifting to the employee, I think, has not shown itself to result in long-term savings because of things like that.
Thank you, Dr. Moore. So unless there are any other questions for the presenters, I do have a question for you all, the attendees. So I know we had at least several people that say that, can't remember the exact verbiage, but yes, I use the term social determinants of health every single day. And so I'm curious, of those on this meeting today, are there any strategies that you've implemented in your work site or you plan to implement that you've either seen success with or that you've learned today that you think would be easily doable in your work site that you'd like to share? All right. Let you think that one over a little bit. Well, unless there are any other questions or thoughts from the group, Shelley, I'll turn it over to you for Health and Wellness Coalition updates, and if you have any other final thoughts.
Okay, thank you, Matt, and thank you again to the speakers. I appreciate the poll with the multidisciplinary approach. I think that that's what we did on this call today by bringing in these 3 experts representing different areas. And I just encourage you to continue to look at that in your organization and see how you can work with organizations that were listed on the slide that Karen provided. And also, you know, continue to think about this topic. So this was a new topic for Think Tank, and we had a good participation on the call. And so I'm hoping that you all are just doing a lot of deep thinking about what you can do in your organization and which one of Karen's suggestions you're planning to implement in the next 12 months. So like Matt said, we're going to send out this recording. We'll send out the slides. If you have any questions or want to have a further discussion about this topic, definitely reach out to Matt or myself, and we'd love to facilitate that for you. So what's coming up for the Health and Wellness Coalition? We have our final Think Tank series in 2020 on December 8th. And so I'm going to send out a calendar invite to those who are registered already for Think Tank by the end of the week so that you could hold that on your calendar. As you know, I've been sending out invites to all past Think Tank attendees for these virtual sessions, and so you can be expecting that. And if you're not a past attendee on Think Tank, but you want to be added to the session, just let me know, and I'd be happy to add that to your list, to my list. So I'm going to turn it over to Matt for his Kansas Business Group on health announcements.
Sure, I'm off mute. Well, I just want to say thank you again so much to our 3 presenters. The information that you brought today was so incredibly valuable, and I personally learned a lot, and I hope everybody on this call took some actionable takeaways away also. For the Kansas Business Group on Health, we do, like I mentioned earlier, several trainings throughout the year. We were very glad to partner with the Health and Wellness Coalition for this training. In 2021, we have our topics lined up for 2021, so we hope that you'll check us out and come to some of our other sessions. We'll be looking at things on related to data. We'll be looking at things related to pharmacy benefit management, pharmaceuticals in general, I should say, mental health, telehealth, and several others. And so we'll have our educational schedule on our website here soon for 2021. We also have our 2 conferences that we do each year. The next one coming up is our Innovation Summit, which will happen at the end of January. And
Hey, Matt, I think we lost your audio.
Can you hear me?
Yes.
Sorry, I think my phone just gave out on me. So we have lots of resources for you as the employer and your broker consultant as you're developing your plan for your benefits each year. And so we hope that you'll check us out for not only our training and education resources that we offer, but also some of the other member services that we have for reducing healthcare costs as well. So that's all from me. Thank you again to our presenters. Thank you all for coming to this session on social determinants of health. Like Shelley mentioned, we'll be sending out the slides and the recording of this presentation after this. If you have any questions, please feel free to reach out to Shelley or myself. So thank you all. Hope you have a great rest of your day, and we'll talk to you soon.
Thanks, Matt.
Thanks, Matt.
Bye.
Thanks so
everyone.
much.
Thanks, Shelley.